Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is Antiphospholipid Syndrome. So what is Antiphospholipid Syndrome, which from here on in will be called APS? It's an autoimmune multisystem disease associated with recurrent venous and arterial thromboses and the presence of specific antibodies. Anticardiolipin antibodies, which are one of the three types of antibodies associated with this condition, are actually present in up to 4% of the normal population. 20% of patients with lupus have anticardiolipin or lupus anticoagulant antibodies, which is another form of the antibody related to APS. There are two forms of APS, primary and secondary. So primary APS is a standalone condition associated with anticardiolipin, anti-beta-2 glycoprotein, or lupus anticoagulant antibodies, and more than one can be present in the same person. Secondary APS is in the presence of an underlying autoimmune condition, the most common being lupus. Diagnosis of APS requires one clinical criterion, which is thrombosis or pregnancy loss, plus one laboratory criterion, which is any of the three antibodies, and they should be positive on 2 occasions 12 weeks apart, and we will talk about the antibodies in greater depth later in this presentation. Antiphospholipid syndrome is characterised mainly by clotting abnormalities leading to thromboses, and this can manifest in various ways, for example, DVTs, PEs, arterial thromboses, strokes, and TIAs, and can also affect other organs such as the liver and kidneys. APS can cause a very typical rash, which looks like a net and is therefore called livedo reticularis, and for example, this can manifest on the legs. APS does lead to thrombocytopenia, and in women it can manifest as recurrent pregnancy loss and miscarriages. Several investigations should be performed in someone you're suspecting of APS, and actually the first presentation may be, for example, an unexplained PE or DVT, or indeed pregnancy loss. So, as with all conditions, bedside observations and a urine dip are useful. Bloods should be performed, including the basic biochemistry and Rheumatology blood tests, but also the specific antibodies to this condition, so anticardiolipin, lupus anticoagulant, and beta-2 glycoprotein. These need to be positive on more than one occasion 12 weeks apart. An autoimmune screen is also indicated in these patients to check for secondary causes of APS, so for example a lupus screen. Imaging really depends on the organs involved and the manifestations. So, for example, if someone presents with possible stroke or TIA, then it may be indicated to do CT heads or MRAs as well. Treatment involves the multidisciplinary team. So, for example, these patients may be under Haematology and Rheumatology, as well as any other specialties which are involved depending on organ involvement. Lifelong warfarin is required following any event, and it's essential to correct any modifiable risk factors for thrombosis, such as stopping smoking and avoiding estrogen use. So let's do some questions. So a 50-year-old sailor presents with a left swollen calf. He is found to have positive antiphospholipid antibodies. Which of the following statements is correct? So the statements are: he can be diagnosed with antiphospholipid syndrome straight away. Positive APS antibodies may lead to a false positive syphilis VDRL test. Antiphospholipid syndrome cannot be diagnosed in males. Apixaban would be indicated if APS is confirmed. And a positive D-dimer is diagnostic of a DVT. So the correct answer here is that a positive APS antibody test may lead to a false positive syphilis VDRL test. So this is quite a tricky question, but it is possible to work out the answer, as is the case with many MRCP and MCQs, by first of all eliminating the ones that we know are wrong. So taking the first answer, which says he can be diagnosed with antiphospholipid syndrome straight away. We know this is not true because the antibodies have to be positive on more than one occasion 12 weeks apart, and as far as we know from this vignette, they've only been tested once. So we can eliminate number 1. Number 3 says that antiphospholipid syndrome cannot be diagnosed in males, which is also false. It can affect males and females. Number 4 says that apixaban would be indicated if APS is confirmed. This is not true. Warfarin is the first line of treatment if someone has had an event and they are found to have antiphospholipid syndrome. And we know that a positive D-dimer is not diagnostic for DVT, and there are several reasons why this may be raised. So this leaves us with the second answer as being correct. So thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss out on our next episode. Let us know in the comments which topics you'd like to hear about in future, and we will see you in our next episode.